Hello, Sharishvila. I'm Karen Swirsky, your MD board member, and I am here with Dr. Louise Harris. Louise is a physician at UHN. She's a cardiologist, and she's told me a little bit about her electrophysiology practice. I'm a family doctor at St. Mike's, and we're both having an experience of COVID, different from yours, but that we'd love to share with you. Dr. Harris.
So, as Karen's indicated, I am a cardiologist at the Toronto General, and I think the rabbi was keen for us to talk about our experience with COVID from within the hospital environment. And as I said, my background is cardiology, so I'm not infectious diseases, I'm not respirology, I'm not an epidemiologist, but I do hope we'll be able to give you some helpful insights into dealing with the current COVID pandemic.
That's true. So another disclaimer we both wanted to just put out there is that whatever we talk about isn't intended for personal health advice, but rather general guidance, and everyone should seek the opinion of their own healthcare provider with regards to their own medical care. So I thought I'd find out from you, Louise, what your sort of day-to-day pre-COVID tasks are, so that we can hear how COVID changed all that and how you had to rise to that challenge.
So my particular interest within cardiology is a subspecialty called electrophysiology, and that largely revolves around rhythm problems in the heart, fast heartbeats, slow heartbeats. I'm sure many of you are familiar with diagnoses such as atrial fibrillation, and that's one of the irregular rhythms that we deal with. And a lot of what I deal with is also involves people who require pacemakers for a slow heartbeat, or sometimes implantable defibrillators, which are devices that can treat fast and slow heartbeats. And so much of my day-to-day would be in clinics where we serve a population with devices and troubleshoot problems. I also see patients in my office, and I do a fair amount of teaching and coaching, mentoring, and some research, less so than I used to, but that would be my day-to-day experience. And that was pre-COVID.
All right. So tell us how this coronavirus pandemic changed your clinical life.
So I think it's important to remember SARS. And I was on staff when SARS came through the door. And in fact, the Toronto General at that time was actually ground zero for SARS. And we were caught quite unaware. It was a very similar situation. A patient came from China and came to the emergency department with a cough, and nobody was familiar with the condition. And another gentleman in the emergency department with this patient subsequently became infected with SARS, and it spread from there. And that was a big wake-up call within the hospital as to how an emergency department should be run. And they learned a lot of lessons from SARS. When we became aware of COVID, the first thing that changed was instructions within the emergency department to protect the patients and the staff from a recurrence of what happened with SARS. But in addition, because of the experiences in Italy and New York that were unfolding rather alarmingly in real time, the hospital made enormous efforts to prepare for the onslaught of anticipated patients requiring intensive care unit beds and ventilators. And as a consequence, within a matter of about 48 hours, we had to cancel all non-emergency procedures, and the hospital had a task force that set about creating anticipated extended intensive care unit beds. There was a lot of modeling going on at the level of the provincial government, at Queen's Park, trying to plan for the capacity. Unfortunately, that never came to pass, certainly within our hospital. We have never exceeded the standard ICU capacity, where there's never been a shortage of ventilators, and all the anticipated surge units were never required, which is very fortunate. I looked at the numbers today, and at the University Health Network that comprises both the Toronto General and the Toronto Western, as well as the Rehab Institute and Princess Margaret. At no point in the last several months have there been more than, I think the total number of patients treated has been 260, so well within the capacity of the hospital. But the impact on all other services was enormous. We were effectively full tilt one day and zero the next.
Yes, as a cardiologist seeing outpatients, I'm sure that was the major impact that you saw.
Yes, and so there had already been within the cardiology program a big move to move a lot of follow-up of care of patients to virtual care. So we have a very large heart function program. It serves many thousands of patients across the province who come for specialized care, because as many of you will know, the Toronto General is a leading hospital for heart transplants. Well, indeed, for transplantation of any organ. It's one of the top hospitals in the world for lung transplant, heart transplants, and on and on. And so they have a large population of patients from around the province who are being worked up for possible heart transplant or for possible advanced cardiac care. And so because it's difficult for many of these patients to travel, and because of the numbers of patients, and because of their day-to-day care needing a lot of input, there's been a move over the past year or two to move a lot of this to virtual care. And some of you may actually be aware of or know somebody who's on something called the Medley program that enables patients to gather their own data and submit them on a daily basis and get feedback from a nurse specialized in heart failure management. So the hospital has been very supportive of broadening the scope of virtual care. And as a consequence, very rapidly people moved to doing virtual care for a lot of cardiac patients, which has been a big help. It doesn't take the place of in-hospital visits, but it certainly enabled us to direct patients' care and try to guide patients who might need admission into hospital.
So over the course of the last 2 years, although you were gradually moving to more virtual care because of the population and the geographics that you reached, this was quite a different set of circumstances that mid-March weekend when, like you said, we did a 180 turn and changed our model of care quite rapidly. Can you tell us more about how you managed the difficulties there?
So it was quite challenging in many respects because we were balancing two things: dealing with patients whose procedures had been cancelled or whose care had abruptly been redirected, but also there was also the increasing recognition and trying to understand the consequences of COVID as well, because there's certainly been a fair amount of cardiac involvement, and so we were balancing both aspects. We did. This was a model that we've used previously within my group. We set up a daily virtual meeting, because the other thing that people need to understand is that all our connections, all our meetings, all our groups had to go virtual. So all the administration within the hospital or a dialogue between ourselves became virtual. So we really were not having much contact physically between physicians and support staff and nurses. So all of that went virtual. And in order to ease the burden of decision making as to whom to cancel, whom to bring in, we formed a chat, much as we're doing now, where we would group every day, and still do, to make decisions as to, is it safe to cancel this person's procedure? And sometimes there's an element of the unknown, and the guidelines that most of us were operating under were, if this patient will not come to harm within a 2-week frame, then this activity should not take place. And sometimes, as all of us know, life isn't that binary. It isn't black and white. You can't be limited by a yes/no answer, and often it's very nuanced. And that was quite challenging, but it was very helpful for all of us to be supportive and make group decisions. And I think that has been a very welcome change. And it also enabled us to communicate with all our support staff. So I think one of the really valuable things that's come out of this is that you can bring a lot of people together virtually, and it facilitates communication, certainly when looking after patients, because it doesn't take people out of their environment. They can still be on the ward, they can still be in their offices, and you can bring nurses, support staff, physicians, coordinators very quickly into a group and improve communication. And I think that's been a real strength that we've gained out of this experience.
So I sense that despite the lack of sometimes evidence of whether a scenario would, cause undue harm to a patient in the next 2 weeks, and sort of weighing the risks of contracting COVID in a hospital or outpatient setting against the risks of their condition and not seeing someone in person. Although that wasn't necessarily evidence-based at the time, we were all comforted by collaborating with other, yourself, other cardiologists, or, in the case where there was a nurse who was checking in on a patient, collaborating that way to find out how people were doing. You took comfort, and probably we all gained some higher quality decisions because of that collaboration. So now what I'm wondering, because I know that this is the challenge in terms of the next phase, both from a public health perspective and also from a primary care perspective, what does reopening more look like? What does seeing more than just those people who, for my case, need vaccines or prenatal visits, or people who we think harm will come in the next 2 weeks? What does the next phase look like for cardiology? Who's getting seen now, or who will get seen in 1 month if things continue to go in the direction they're going?
I think one of the remarkable things about this pandemic is the many unknowns, and we continue to be challenged, whether it is understanding the disease, whether it is treatment options that we don't have, whether it's being thrown curveballs continuously, as for example with children now, and the potential for this multi-inflammatory system condition. And so part of the difficulty in changing the direction now is the immediate reaction was we have to do something to deal with the onslaught in the intensive care units and ventilators. And as I said earlier, that didn't come to pass, so that was the immediate reaction. Now, revising the needs within the hospital is taken a different direction, in that certain things remain, resources remain quite limited. So whereas there's bed capacity, there's nursing capacity, physician capacity, there are a lot of things that are marginal, such as shortages of drugs. So a lot of medications that are used for sedation, for pain management, are globally in short supply. Many of the drugs that are used come from China and India. And because of the global situation, there is actually a shortage of commonly used pain medications. And so that has to be borne in mind. And similarly, even though the whole concept of PPE, personal protection, it has moderated and is not quite as acute as it was at the onset, the hospital still has to be very mindful that there are limited supplies. There are even limited supplies of globally of things such as hand sanitizers. So when the hospital looks at increasing outpatient procedures or reintroducing standard operations, they have to be mindful of the need of those items. And in the back of everybody's mind is still whether COVID is going to ramp up again, because that is one of the total unknowns, is which direction is the wind blowing, and we don't really know, but everybody seems fairly certain that there will be an increase in the number of severe cases at some point. And so it's a balancing act between allowing important cardiac procedures such as angiograms, pacemakers, heart surgeries to resume without putting the system in jeopardy. And so it's small steps. And I see the same thing in the business world. It's allowing an increase in volumes in small number and monitoring the impact. And if things are successful, increasing the volume and monitoring that impact. But it is all very tentative and is constantly being monitored and reviewed. So we are certainly doing more than we were back in March. And one of the interesting aspects of this is that many patients don't want to come to the hospital for their procedures, and that is a concern as well. And I think people do need to understand that the hospitals are being very careful and screening patients, swabbing patients if needed, swabbing physicians and nurses and support staff as needed, and being very mindful of not wanting transmission either from patients to staff or from staff to patients. And I think it's important for people to realize that this is probably one of the better times to come in and get your procedure, because the volumes are not back up. Everybody is very cautious, and we are anticipating that things may change by the fall, and they will be increasing in numbers again. So hospitals right across North America are trying to reassure patients that if you need a procedure done, hospitals are safe and procedures should go ahead.
Yes, I find this is a challenge too, convincing especially an elderly patient or a more senior patient who's been told, the safest thing for you to do is to, narrow your bubble, as keep your bubble as tight as possible and come into contact with as few people and services as possible. It's hard to convince those patients to go to the hospital when you suspect something like a stroke or a heart attack. And I think good advice is just to listen to your own healthcare provider because they know where they're sending you and they know what they're talking to you about at that moment, and their worry sort of helps balance out your worry about the opposite thing.
No, very much so. And I think that right across North America, people have been concerned about the fact that there have been fewer heart attacks treated. People with strokes have not been coming to hospital, and that is a concern. That people should understand that the hospitals are doing their best to protect the patients and protect the staff. And if you need a procedure, it should go ahead. Obviously, if something is somewhat elective and in discussion with your physician, they think it is safe to postpone, then that's fine to do. But if the risks of postponing are significant, then it is best to go ahead. And I do think that this is a relatively good time to get anything done under the current situation. And I think people need to appreciate it's not going to change anytime soon. I think that's important, that this tentative sense of the virus being in the community is going to be there at least until the next year, and people shouldn't delay.
Another thing I wanted to mention about what makes hospitals safe right now is, yes, keeping a close eye on all those working there and providing the proper equipment when that's what sort of determines how many people we see, is also how much personal protective equipment we have as an institution. But also the idea of physical spacing is happening within hospitals. So I don't know about your hospital, but our hospital screening happens for possible COVID or not COVID, right at the door, even before triage, which for our congregants means, discerning whether your issue is very acute, needing immediate attention, or can wait for less immediate attention. And so the separation is happening very early on in the emergency departments, and also spacing even within the sort of safe zone of the non-COVID screen, so that there's 2 meters apart and masks at the door. But I think that that's important for people to understand, that going to the grocery store is no safer than going to the hospital. Every institution is practicing this physical distancing. And so except for the moments that you need to have contact with healthcare providers, all those precautions are taken. So it's helpful to realize the physical space that's been created by all these measures that you spoke of.
And I think that patients should know that, people should know that on the websites of the hospitals, mostly they are posting, they are being transparent about the numbers of patients, where they're located, what's happening within the hospital. So it is possible to be informed, and sometimes the news headlines can be a little misleading, and I think that, as you mentioned, Karen, all hospitals have screening procedures. Anybody who is coming for an outpatient procedure or visit is screened by phone before, screened at the door, masking, universal masking policy, hand washing, social distancing, all of that is going on all day, every day within the four walls of these institutions.
So maybe we should talk about that then now, the physical distancing. I decided to use the term physical distancing because social distancing started to feel really lonely. And I know that that's a challenge for everyone, is this idea of social distancing, which is not actually what any of us are doing, right? Here we are having the Zoom. I know that the shul has a l'chaim every Thursday night. You know, there's plenty of opportunities to smile at your 2 meter away neighbor. Um, so yeah, perhaps we can just talk as physicians about the general public health recommendations and how important those are, to kind of let this dimmer switch in the healthcare field starts to, so we can start to see the availability of starting to see patients a little bit more again.
So I think that where this COVID has been so extraordinary is that a lot of the time the guidelines appear to be changing. We appear to be sort of having contradictory statements. I think what has emerged, and everybody's learning, and I think the congregation should know that there's been an extraordinary collaboration, not just within each hospital and within each group, but actually globally. So as information, and I'm talking about information from physicians within China, physicians within Europe, was emerging. People were sharing continuously. I don't know if you've had that experience, Karen, but people have been sharing in the most extraordinary manner the kind of problems that they've encountered, because much of this condition is unlike any other condition we've seen before. And people, I guess in some ways we were fortunate here to be able to learn from some of the negative experiences, both in China and in Italy. And so it's become obvious that some of the biggest factors for transmission, for example, are one of them is the viral load. And in Italy, certainly the physicians looking after the patients took an enormous hit. And it was believed to be that they were looking after vast numbers of people who were acutely unwell and coughing. And so when somebody has the virus and is coughing and you get that acute viral load, that represents a huge risk for coming down with the illness. But the other thing that has emerged is that if you're in a confined space and there are large numbers of people and one person is sick, and you do not have good ventilation, then you can make many, many people sick. So it's really a mixture of the viral load, being in close contact with somebody who's acutely ill, and then being in a confined space with a lot of people and poor ventilation with somebody who's not apparently as ill. What then came out much later was this concept of the asymptomatic spreader, and that is that remains a sort of a curious phenomenon. The first hint of that was really interestingly from one of the cruises. I think it was the Diamond Princess, which was one of the first ships, and I think that was off Japan. They ultimately swabbed everybody. Everybody was tested on the ship, and they came up with the number of 20% of people who tested positive never had any symptoms. And so that, I think, kind of threw a spanner into the works. So the concept of physical distancing is that if somebody is talking and has the condition, then if you are 2 meters apart, you are probably relatively protected. But if somebody is coughing, it's not clear that that 2 meters is actually sufficient. But for the average person that you encounter on the street who's walking along, not coughing, looking fine, then being 2 meters away means that when you're breathing, you're unlikely to spread the virus. So being outside is really important, and I think everybody acknowledges that it's really important to be out, but to be careful when you're out. Fresh air is important, and people should get outside.
Yes, I'm talking about sunshine a lot with my patients, for sure.
I think there's also a lot of fear around the unknown, and there is an element of the unknown. And you read things in the newspaper about surfaces, about door handles, and I think that causes a lot of anxiety. And I think the best thing there is we do have to go about our lives, and I do think that being conscious of what your hands are touching when you're not in your own environment. Somebody wrote an article about what they called your safe space. So if within your home, when you come in the front door, you wash your hands the way you're supposed to, and that is your personal space, then that's your safe space, and you can do what you want to within that space. But when you're outside, or when you're going to the grocery store, or when I'm at work, I'm conscious all the time of what my hands are touching, and making sure that I wash them or use hand sanitizer if I've touched a surface that I don't know who's touched it before me. But I think there are certain things now that are recognized as probably low risk, like reading the newspaper, for example. I know that, or opening parcels, or those are probably all very low risk settings.
Yes. So is there anything else we want to share? Maybe is there anything else you, Louise, wants to share with the Kehillat Torah congregation at this challenging time?
I think one of the things I think a lot of people want to know it revolves around testing and who should be tested and why it keeps on changing. And I think that I saw just today that they are now looking at testing larger groups where people are asymptomatic, trying to get a better sense of where the cases are originating. Testing is important to try to identify and isolate people and protect those around them. Part of the challenge has testing now in Ontario. If you are in a major center and need to be tested, you have answers in under 24 hours. So that, and it is available. It is being broadened. There has been talk of point of care testing, and some of those, I think it was a rush to market, and so I think the validity of those has been sort of thrown into, there's an element of uncertainty, but if anybody needs to be tested, they certainly are opening it. They're not short of testing. That's the difference between Ontario and the US. There's now lots of capacity for testing if needed.
Yeah. I work in the shelter system. I work in the COVID assessment center at St. Mike's, and we are just starting this weekend, started to test anyone with any symptoms. Prior to the weekend, it would require some other, co-features. And for asymptomatic carrier status, only checking vulnerable populations, like you mentioned. So we're going into the shelter system. The challenge with that is that we still think we have about a 30% rate of false negatives for swabs in an asymptomatic person, meaning if you're if you don't have an illness, but you're harboring the virus and you get the nasal swab, we don't know how accurate a negative result is, or a no, you don't have it result is. So I think we won't really have a good sense of that until we see some blood work testing, some serology, antibody testing.
And even the antibody testing, there's so much uncertainty about what does it mean, when do antibodies become positive. And I think I saw an article today, I think it was out of Singapore, indicating that people are no longer shedding virus after, I think they said 11 days. So people who have the condition do not appear to be shedding it after 11 days, even if you can still measure it in their body. So there's so much we don't know. And I think that we have to accept that there will be ongoing changes in guidelines and regulations as the information becomes available.
Yeah, I like to give people the advice that you have to temper what you hear in the news with the knowledge of where that information is from, and think about where we are relative to where some of these other locations are. We have a universal healthcare system that we should all be grateful for now if we've never been in the past, which hopefully we have been. And both our, privileged and our marginalized populations are able to get tested and treatment. Maybe we'll briefly talk about the treatment or the support that's required for patients with COVID, and then we should just tie things up.
Okay. So treatment is best described as supportive, which means that at the present time, all you can do is respond to the system injury that the patient presents with. So for many people, it might be respiratory. For others, it could be related to kidney issues, cardiac issues. And so at the present time, the lessons learned, as I said earlier, from both China, now the States and Italy, have actually made some progress in managing patients. An example would be that early on, when people presented with low oxygen levels, there was a move to ventilate them early, and then people learned that often you could avoid that by just using high flow oxygen. Even the care of whether you keep somebody on their back or on their stomach for ventilation, there have been a lot of lessons learned that have made the care, that have facilitated the care of the acutely sick patient. There really are no bona fide treatments. When hydroxychloroquine surfaced early on, many of us had grave, it was certainly from a cardiology point of view, had grave concerns, whereas those chloroquine and hydroxychloroquine have been used for the treatment of rheumatoid arthritis and other conditions, and used extensively and with good effect. The patients who are in the intensive care unit with COVID represent a very different population, often on many other drugs, including antibiotics that can have cardiac effects, and so it represents a very different scenario with very different potential for harm. Then they've been looking at retrovirals, which are drugs that are specifically designed to treat viral infections. And the one that I can never pronounce, remdesivir, that is currently being looked at, was originally looked at for Ebola. I think with many of these new ideas, new drugs that are being evaluated, there is one consistent theme that seems to emerge, and that is, if you're going to treat these conditions, you have to treat them when the patient is not severely ill. So what seems to happen is the initial insult is a viral insult and a viral type of pneumonia. But then you move away from a direct infection to the consequences of that infection, by which I mean there is a process of uh, an immune reaction that the virus incites within the body. And so then it transitions from being a viral infection to being an immune response where you're having inflammation, and a lot of what's been reported from the cardiac effects is inflammatory response within the muscle and within the arteries. And so once you get into that stage, it is also an immune response within the coagulation system. And what they were reporting, certainly in Mount Sinai, was clotting disorders, both in tiny vessels and in large vessels. And all of that is viewed now to be some type of autoimmune response. And so I think the thinking is, if you can get to the viral infection before that has triggered, then maybe you can moderate that very severe inflammatory response, which seems to be responsible for a lot of the very devastating effects of this condition. So I think, so I think that right now we don't have a definitive treatment, and there are certainly lessons learned from the experience of others that have definitely improved the care of these patients, but it's still very much supportive care and very much a learning experience for these various drugs, but with nothing definitive at this time.
And hopeful about the way that internationally, globally, the research communities are gathering data and collaborating with that, which will hopefully generate some results that are trustworthy sooner than if it had been a single nation generating those results. So that's a kind of exciting on the horizon.
Well, and that is quite remarkable for all that has been said about the experience within Wuhan and China. The Chinese physicians very quickly did genomic sequencing of the virus and made that globally available for people to start developing vaccines. So understanding the structure of the virus, a lot of that work was done in China and disseminated widely for people to start working on vaccines. So there is a huge amount of global collaboration. Of course, there's also a certain level of everybody wants to be first past the post, but I think that there truly has been an amazing amount of communication and collaboration.
Yeah, and exciting to see what that might glean as well. So perhaps on that note, we should propose an update to this chat in the fall, if we're so lucky to be talking about some good news then. It was a really honor to get to chat one-on-one with a cardiologist in the thick of it. So I look forward to if we can do that again.
And it's been my pleasure chatting with you. And I hope everybody within the congregation has got something out of this. And actually, it would be nice if we did do a follow-up, to have people send in questions, and then we could try to answer things that we may not have addressed here, or new things that may arise going forward.
Sounds perfect. All right. Well, good night.
Great. All right. Good night. Good night to you.